Hi, guys. So, today we're going to be diving into schizophrenia spectrum and other psychotic disorders. Before we look at the clinical data, we are going to start with an experiential learning exercise. I want us to build genuine clinical empathy for the cognitive load our patients carry. So, please grab a single piece of paper. You won't need a pen or pencil. And for the most immersive experience, put on your earbuds or headphones now. In a moment, I will have you complete an adjusted mini mental state examination. And while you try to focus on my instructions, I will play an audio track that simulates the type of auditory hallucinations, the voices, that a person experiencing schizophrenia might hear. This exercise can be intense, and if at any point you feel overwhelmed or uncomfortable, you have my full permission to pause or fast forward through this activity. No explanations needed. Just go ahead and do that. So let's put on our headphones, grab that piece of paper, and begin. Now I want you to remember these 5 words: ape, white, pen, globe, and car. Then I want you to read the paragraph and think about what it says and think about what your response would be. Now I want you to count back by 7, starting at 100. Stop after 5 reductions. Okay, now take that piece of paper I had you get and fold it in half and then put it down. Okay, now lastly, say out loud, what were those 5 words I wanted you to remember? Now that you've experienced a fraction of that distraction, let's look at what's happening biologically and clinically. As you just felt, schizophrenia profoundly disrupts a person's ability to perceive reality accurately, think clearly, or use language normally. It is a devastating brain disease that typically strikes young people in their teens or early 20s, just as they are starting their productive adult lives. It is vital to understand that psychosis itself is not a diagnosis. It is a symptom cluster characterized by a total inability to recognize reality. This manifests primarily through 2 pillars: delusions, which are fixated false beliefs and thought, and hallucinations, which are false sensory perceptions, like the voices you just heard. While schizophrenia is treatable, it is a chronic condition, meaning it's not curable. When we look across the spectrum, we see distinct diagnoses. Delusional disorder is unique because the individual experiences one or more non bizarre delusions for at least a month, but their overall psychosocial functioning remains largely unimpaired. They can typically still hold down a job and manage daily life. These delusions generally fall into specific themes, such as persecutory, feeling targeted, grandiose, jealous, or somatic, and this disorder tends to have a later age of onset. This table outlines our diagnostic timelines, which are crucial for testing and clinical mapping. For a diagnosis of schizophrenia, continuous signs of disturbance must persist for at least 6 months, including at least 1 month of active phase symptoms like delusions, hallucinations, or disorganized speech. Schizoaffective disorder bridges the gap between psychosis and mood disorders. The patient meets the criteria for schizophrenia, but also experiences concurrent major depressive or manic episodes for more than half of the illness's duration. Schizophreniform disorder presents exactly like schizophrenia, but the crucial differentiator is time. The symptoms last less than 6 months. And then finally, delusional disorder involves themes like grandiosity or persecution lasting a month or longer without the broader cognitive decline seen in schizophrenia. So what causes this? The prevailing neurochemical model is the dopamine hypothesis, alongside serotonin alterations, which shows that brain chemistry and activity are fundamentally different in individuals with schizophrenia. However, biology isn't the entire story. Schizophrenia most likely occurs due to a complex combination of inherited genetic vulnerabilities interacting with extreme non-genetic stressors early in life, such as viral infections, birth injuries, nutritional deficiencies, or early head trauma.
Schizophrenia is a potentially severe psychiatric condition that involves a variety of symptoms. The symptoms of schizophrenia are often categorized as positive, negative, or cognitive. Positive symptoms involve the development of a behavior or thought pattern that isn't normally present, such as hallucinations and/or delusions. Negative symptoms involve the loss of a normal function and include lack of motivation, blunted emotion, or difficulty experiencing pleasure. Cognitive symptoms are those that affect someone's ability to think clearly and include deficits in attention, memory, and/or concentration. The neuroscience of schizophrenia has been difficult to sort out, but a great deal of research has focused on neurotransmitter abnormalities at the root of the disorder. Dopamine has received much of this attention, with the general hypothesis being that dopamine activity is too high in certain parts of the brain in schizophrenia. This hypothesis was originally formulated based on the findings that drugs used to treat schizophrenia act to reduce dopamine activity, and drugs that increase dopamine levels, such as amphetamine, can induce behavior that in some ways resembles the psychotic states schizophrenic patients experience. The idea that increased dopamine activity plays a role in schizophrenic symptoms is now supported by a large body of evidence. However, dopamine irregularities alone do not seem to explain all the symptoms of schizophrenia. Glutamate abnormalities, such as dysfunctional glutamate receptors, also occur in schizophrenia, and these may be capable of accounting for some negative and cognitive symptoms, something that dopamine levels have been less successful in explaining. Additionally, it has been proposed that dysfunction in glutamate systems may precede and lead to the dopamine hyperactivity observed in schizophrenia. While it's uncertain what causes these neurotransmitter abnormalities to emerge in the first place, it's generally believed that schizophrenia can be traced back to disruptions in early neural development that occur due to the influence of both genetic and environmental factors.
Schizophrenia rarely exists in a vacuum. Comorbidities are incredibly common, particularly substance use, anxiety, and severe depression. When evaluating the course of the disease, it varies widely. Some individuals experience acute exacerbations, followed by periods of partial recovery, while others face a more chronic, progressive decline. Our goal as nurses is to optimize functioning at every stage of this timeline. We group the syndrome of schizophrenia into 4 distinct symptom dimensions. Positive symptoms are excess or distorted behaviors added to normal functioning, including hallucinations, delusions, and catatonia. Negative symptoms represent a loss or deficit of normal functioning, such as apathy, avolition, anhedonia, and social withdrawal. Cognitive symptoms involve profound impairments in memory, attention, and the ability to reason or solve problems, exactly the deficits you felt during our simulation. And mood symptoms include depression, anxiety, and a high risk for suicidality, which must continuously assess. Before we move to the next slide, I want to show you a brief video demonstrating a specific presentation of catatonia. In this clip, you are going to see 2 distinct clinical phenomena: waxy flexibility and automatic obedience. Waxy flexibility is when a patient's limbs can be moved into a posture by an examiner, and the patient will hold that exact position for long periods without moving, almost like a mannequin or a wax figure. Automatic obedience means the patient will blindly, immediately follow any command from the examiner, even if it's illogical, uncomfortable, or potentially harmful, without checking reality. Now, a common misconception is that because catatonia looks like a lack of voluntary movement, it must be a negative symptom. But in psychiatry, it is actually classified as a positive symptom. Remember the definition. Negative symptoms are a loss of normal function, like a lack of emotion or lack of speech. Positive symptoms, however, are an excess distortion or addition to normal brain processing. Catatonia is not the brain shutting down. It is a profound distortion of motor control and processing. The brain is firing excessively and inappropriately, creating an added, abnormal neurological state that locks the body up. Watch how the clinician interacts with the patient in this clip, and pay close attention to the absolute lack of resistance to positioning.
You can put your hands by your side and stand comfortably, John. Sit down, John.
John, sit in the chair. John, sit down.
Okay, you won't fall. Go ahead and sit.
John, sit in the chair.
You won't fall. Sit in the chair. The chair's right there.
Let's break down the four main categories of positive symptoms. Remember, these are all additions or distortions of normal baseline functions. First, alterations in thinking. First, we have alterations in thinking. Delusions. Aside from standard persecutory delusions, we often see thought broadcasting, which is the belief that others can hear your thoughts, thought insertion, the belief that thoughts are being placed into your mind by an outside force, and thought withdrawal, the feeling that your thoughts are actively being stolen or erased. Concrete thinking. This is an inability to think abstractly. If you say, the squeaky wheel gets the grease, a patient with concrete thinking won't understand the metaphor. They will literally think a mechanical wheel needs oil. Thought process issues. We see circumstantiality, giving unnecessary, tedious details before finally getting to the point, and tangentiality, going off on a tangent and never returning to the original point. We also see flight of ideas, where thoughts shift rapidly from one topic to another, barely connected. Second, we have alterations in speech. Next, we look at alterations in speech, which directly reflect a disorganized thought pattern process. Loose associations are ideas of poorly combined and sentences that don't logically flow into one another. Neologisms, words that the patient invents to have and that have a meaning only to them. Echolalia is the pathological repeating of another person's words, exactly like an echo. Clang association, choosing words based on their sound or rhyming ability rather than their meaning, like saying the cat sat on the mat, fat bat hat. And then word salad. This is the most extreme form of disorganization. It is a completely jumbled mixture of words that has absolutely no meaning or semantic structure. Third is alterations in perception. The third bucket is alterations in perception. Hallucinations, while auditory hallucinations are the most common, as you experienced in our simulation, they can occur across any sensory pathway: visual, olfactory, gustatory, which is taste, or tactile, feeling things on the skin. Pay special attention to command hallucinations. These are voices instructing the patient to perform an action, which creates an immediate safety risk. Then there's depersonalization or derealization. These are profound distortions of reality. In depersonalization, the patient feels disconnected or detached from their own body. They might feel like they are looking at themselves from the outside, or that their limbs don't belong to them. In derealization, they feel detached from their environment. The outside world feels fake, dreamlike, or artificial. And then lastly, alterations in behavior.
Finally, we have alterations in behavior, which include the catatonic features we discussed. This ranges from extreme motor agitation, which is aimless, frantic pacing or moving, to stereotyped behaviors, which are repetitive, purposeless movements like rocking back and forth or back and forth continuously. It also includes automatic obedience and waxy flexibility, which we just watched in this clip, as well as a stupor, a state of near unconsciousness and complete lack of reactivity, and negativism, where the patient actively resists or does the exact opposite of what they are asked to do. Negative symptoms are often the most debilitating long-term aspects of the illness. Think of them as the A's. Affective blunting is a severe reduction in emotional expression. Anergy is a complete lack of energy or persistence. Anhedonia is the inability to experience pleasure. And avolition is a lack of motivation to initiate basic daily tasks like grooming. We also see allogia, which is a poverty of speech, alongside thought blocking, where a patient suddenly stops speaking mid-sentence due to an internal interruption. Historically, schizophrenia has been categorized into presentation types. Paranoid type, dominated by hostile, persecutory, or grandiose delusions. Disorganized type, marked by regressed, incoherent speech and flat affect. Catatonic type, presenting with severe psychomotor disturbances. And then undifferentiated and residual types. Schizophrenia rarely exists in a vacuum. Comorbidities are incredibly common, particularly substance use, anxiety, and severe depression. When evaluating the course of the disease, it varies widely. Some individuals experience acute exacerbations, followed by periods of partial recovery, while others face a more chronic, progressive decline. Our goal as nurses is to optimize functioning at every stage of this timeline. When applying the nursing process, your assessment must encompass the patient's history, current symptoms, mental status, support systems, and any dual diagnoses. Based on those findings, our priority nursing diagnoses focus heavily on safety, such as risk for self or other directed violence. We also address cognitive and functional needs through diagnoses like disturbed thought process, impaired verbal communication, and self-care deficits. Treatment planning changes depending on the clinical phase. In phase 1, the acute phase, the patient is in crisis. Our immediate focus is stabilization, psychopharmacologic treatment, safety through psychiatric evaluation, and directive supportive communication within a structured, safe milieu. In phase 2 and 3, stabilization and maintenance, the focus shifts to the long game. This involves family psychoeducation, teaching disease and medication management, social skills enhancement, identifying early signs of relapse, and encouraging non-threatening social interactions to improve functional deficits. Our primary strategies for communicating with these patients are centered on lowering their anxiety, decreasing defensive patterns, and raising self-worth. To achieve this, our communication must be highly intentional. For hallucinations, always try to understand what the voices are saying. If the messages are suicidal or homicidal, immediate safety measures are mandatory. Approach the patient non-judgmentally, maintain eye contact, call them by name, and speak simply. For delusions, remember that delusions are a misinterpretation of cognitive stimuli. Validate their feelings, but do not validate or argue about the delusional content. Never attempt to reason them out of a delusion. For paranoia, paranoid patients may lash out with sharp criticisms. Do not take it personally or react defensively. Use clear language, be honest and consistent with rules, and absolutely avoid whispering or laughing where the patient can see you but cannot hear you. Now I'm going to show you a specific video from the Columbus Division of Police, which is an exceptional textbook example of a crisis intervention team training in action. The patient is experiencing an acute, terrifying persecutory delusion and auditory hallucinations, genuinely believing people are actively trying to kill him. The responding officers utilized highly effective therapeutic communication and de-escalation strategies. So let's get into a breakdown of what they did appropriately.
It's not. Help! Officer, I can't take it. You're gonna shoot y'all. Swear to God. Look out.
I promise
He's gonna
you.
shoot through this door.
Listen, I promise you, no one's gonna shoot me.
Help me.
I will protect you. I promise you.
Let's go.
Okay, I promise you
Go!
nothing's gonna happen to you.
Go! Oh, God. Officer.
What's your first name?
Joel.
Joel. I
Help!
promise you, I will
Oh,
protect
no.
you.
Oh, shit.
I promise you,
Officer.
buddy.
Help. Oh, my God. Come on. Please, officer. Officer, go.
We are going to.
Officer, it's 5 of them. Go. Go.
You're good to go. We've got it, okay?
Officer, go.
Just stay right there. You're fine.
Officer, how many times I gotta tell you?
Just stay right
He's
there.
gonna. Officer, he's dangerous.
I've got officers everywhere.
Where?
They're all around us.
Right now?
Yes, sir.
Help me.
The most critical thing the officers did was separate the patient's reality from his emotions. They never told him, yes, people are trying to kill you. But they also didn't dismiss him by saying, you're crazy, no one is here. Instead, they said phrases like, I know you're scared right now, but you're safe with us. They validated his terror, which made him feel heard while remaining firmly anchored in reality.
Yes, it is.
Hang loose. No, that's the woman you.
That's them.
Oh no, that's the woman that was up there on
He
the
said
porch
that-
with you. I promise you,
You ain't
Joel.
gonna protect me.
I am, man. I am. I am.
No, officer.
Yes.
He's behind you right now in this
No,
truck.
sir. Just
I
chill.
swear to God, right there.
There's
That's
nobody you're
him.
gonna protect. I'm
That's
gonna
him.
protect you. You may shut the door.
Officer,
You may shut the
let
door.
go.
I'm gonna shut the door.
Fuck.
When dealing with a paranoid or terrified patient, their spatial awareness is hyper-reactive. The officers did a masterful job at managing the physical space. They lowered their body language. They did not stand directly over him aggressively with hands on their weapons. They knelt down to his eye level, making themselves appear smaller and less threatening. They maintained their distance. They respected his personal space, giving his nervous system room to breathe instead of crowding him. The internal cognitive load of hearing voices makes it incredibly difficult to process speech. The officers adapted beautifully by speaking slowly and calmly. They avoided shouting or overlapping their voices, which would have added to his sensory overload. Explaining every action before doing it. Before moving closer, touching him, or helping him, they explicitly stated what they were going to do. I'm going to place my right hand here to help you, okay? This prevents a startle response or a misinterpretation of physical touch as an attack. The patient's mind was racing and scanning the room for threats. The main interacting officer repeatedly grounded him by giving him a single, safe point of focus, saying, look at me, keep your eyes on me, focus on my voice. This cut through the external paranoia and the internal auditory hallucinations, pulling him out of the panic loop. And then finally, instead of treating the encounter as a criminal matter or a nuisance call, the officers treated him like a vulnerable human being in extreme pain. They used a compassionate, reassuring tone, constantly reinforcing that their only objective was to keep him safe. This established rapid rapport and allowed them to safely transition him to medical care without any use of force. Antipsychotic medications are our primary tool to alleviate symptoms, but remember, they do not cure the underlying disease, and non-compliance will cause symptoms to return. Conventional or first-generation antipsychotics primarily target positive symptoms like hallucinations. Atypical or second-generation antipsychotics target both positive and negative symptoms. Atypicals generally have fewer motor side effects and are highly effective at treating co-occurring anxiety, depression, and reducing suicidal behavior. Here's your medication breakdown for the first generation agents, categorized by potency. High potency drugs include haloperidol, Haldol, and flufenazine, Prolixin. While highly effective for acute positive symptoms, high potency agents carry a much higher risk for motor side effects. Low potency agents like chlorpromazine, Thorazine, have a lower risk of motor side effects, but are highly sedating and cause strong anticholinergic effects. And then there's medium potency agents, which include loxapine and perfenazine. Because first-generation medications block dopamine indiscriminately, they carry a high risk of adverse reactions. Chief among these are extrapyramidal symptoms, or EPS, which include akathisia and dystonia. Other severe risks include agranulocytosis, a dangerous drop in white blood cells, lowered seizure thresholds, orthostatic hypotension, and neuroleptic malignant syndrome. Moving to the second generation atypical antipsychotics, these are your mainstays like aripiprazole, Abilify, clozapine, Clozaril, olanzapine, Zyprexa, and risperidol. Because they target serotonin in addition to dopamine, they address both positive and negative symptoms. However, while they minimize motor side effects, as nurses, we must heavily monitor them for metabolic syndrome, weight gain, and altered glucose metabolism. Neuroleptic malignant syndrome is a rare but life-threatening medical emergency caused by acute dopamine receptor blockade, typically from high-potency first-generation drugs or rapid dose increases. Remember the mnemonic FEVER. F is for fever, severe hyperthermia. E is for encephalopathy, altered mental status or delirium. V is for vitals unstable, tachycardia and labile blood pressure. E is for elevated enzymes, specifically elevated creatinine kinase. And then R is for rigidity, severe lead pipe muscle rigidity. Stop the antipsychotic medication immediately. Initiate aggressive cooling and hydration, and transfer the patient to the ICU. Pharmacologic interventions may include muscle relaxants like dantrolene or dopaminergic agents like bromocriptine.
Welcome back. In this video, we'll be talking about neuroleptic malignant syndrome. The cause of neuroleptic malignant syndrome is toxicity of antipsychotic medications, especially those that antagonize the action of dopamine. On top of being a fatal disease, the patient would still have some permanent neurological damage after recovery. And as you can see, the presentation is mainly confusion and restlessness. The patient would keep moving all his muscles, including his tongue, for days, and this will increase myoglobin by causing muscle damage and will also induce fever because of the metabolisms of muscles.
He's got all four of them on, and he's been doing this all day and all night, and he's still not tired. Hey, Brian, can you look over here at me? Hi.
To remember the symptoms of neuroleptic malignant syndrome, just remember the word fever. So F for fever, E for encephalopathy, V for vital dysregulation, E for enzymes elevation, mainly myoglobin, R for rigidity and hyperreflexia. To treat neuroleptic malignant syndrome, we give dantrolene to reduce fever, and we give bromocriptine to agonize D2 receptors.
Finally, let's look at standard extrapyramidal symptoms and how we manage them. Pseudoparkinsonism presents with a shuffling gait, stooped posture, and tremors. Acute dystonia involves painful, involuntary muscle spasms of the tongue, face, and neck. Akathisia is intense, agonizing physical restlessness. Tardive dyskinesia involves involuntary twisting movements, lip smacking, and tongue protrusion. If left unchecked, TD can become permanent. To treat these early side effects, we can lower the antipsychotic dose or prescribed anti-Parkinsonism or anticholinergic medications, most commonly benztropine, Cogentin, or diphenhydramine, Benadryl. We may also augment therapy with mood stabilizers or benzodiazepines to manage acute agitation and anxiety. As we wrap up the nursing process, remember that evaluation must be grounded in reality. Frequently, nursing outcomes are too ambitious or completely omit the patient's personal goals. Change is a slow process that occurs over time. For a patient recovering from a psychotic episodes, that timeline is deeply prolonged. Success isn't measured by a sudden cure, but by marginal, steady improvements in their safety, independence, and quality of life.